Okay, good afternoon, distinguished Professor Yao, ladies and gentlemen. Welcome to the 2025 Asian Cardiovascular Clinical Research Seminar. And the seminar is held by the Interventional Cardiology Council of the Asian Heart Society. I'm Li Yue from the first affiliated hospital of Harbin Medical University. And please allow me to introduce my co-chair, Professor Yao Qiheng. He is a clinical professor at the University of Hong Kong, Assistant Dean of Li Ka-shing Faculty of Medicine, Assistant Dean of the University of Hong Kong Shenzhen Hospital, Director and Chief Physician of Cardiovascular Medicine. And Professor Yao's extensive experience in the diagnosis and treatment of coronary artery disease, valvular heart disease, and cardiomyopathy. And he has published over 200 papers in top-tier journals, including Circulation and the European Heart Journal, etc. And today he is the co-chair. And in that seminar, we have a full presentation. And let me introduce the first speaker. The first speaker is Professor Chao Yang. Professor Chao Yang is from the first affiliated hospital of Harbin Medical University. He is the Deputy Director of Cardiology Ward. And he's the fellow, he's a young doctor of and researcher of FSky. And as we know, he's a well-experienced young interventional expert. And today his topic is progress on calcified nodules.
Okay, thank
Professor
you.
Chao, please.
Thanks for the introduction of Dr. Li and dear professors and guests online. Thank you for your attention. And this is a great opportunity for me to join in the Asian Cardiovascular Clinical Research Seminar. And I will be going to continue to share the topic of mine today, which is progress on management on coronary calcified nodules. I'm Dr. Cao from the first affiliated hospital of Harbin Medical University. Today, I'm going to share my content with the following four items. The first one is a definition. We all understand that the calcified nodule represents the advanced stage of coronary artery calcification, characterized by eccentric protruding calcification and often accompanied by the plaque vulnerability, such as the fibrous cap rupture or thrombus formation. The earliest recognition and discovery of calcified nodule were based on the pathologic studies of patients with sudden cardiac death and other conditions. It was found that the cardiac nodules are a cause that induces thrombotic cardiovascular events. The very first case report of coronary calcified nodule is described in a fading defect on coronary angiography, indicating from this figure that is thought recognized as a thrombus or plaque rupture. However, intravascular imaging with the IVUS, we identified this kind of plaque as a calcified nodule. So this is the very first case report of calcified nodule that is recognized in the human body, which is published in 1996. In year 2000, the AHA, started a new classification of the atherosclerotic plaques, which is coronary nodules. We can see it's listed here, which is defined as a calcified nodule, which is heavily calcified, consisting of calcified plates and the surrounding area of fibrosis, with or without the presence of a necrotic core. Also can be understood as a lesion with fibrous cap disruption and luminous thrombus associated with eruptive, dense, and calcified nodules. So this kind of new idea or identification of the atherosclerotic plaque is defined in year 2000. Currently, imaging is still the main tool for clinical diagnosis of in vivo calcified nodules. At present, we can see coronary artery angiography cannot accurately diagnose calcified nodules. This kind of unclear or failing defect exists in the coronary angiography are often difficult to distinguish from thrombus or plaque rupture from angiography. So theoretically, angiography cannot differentiate very exactly, precisely the calcific nodule from failing defect signs in the angiography. IVUS can be used to detect a calcific nodule. However, due to the limitation of the resolution from intravascular, IVUS, this kind of a protruding calcification with its irregular surface and the presence of the calcification and adjacent proximal and distal segments can be used as a definition of a calcific nodule by IVUS. However, currently, I think all the calcific nodule that is defined by the IVUS were all eruptive ones, I think, due to the resolution limitation. Currently, OCT is the main tool to define and identify the calcific nodule, and also we can use the high resolution OCT to make subgroup classification for the calcific nodule. The second part is prevalence. So we understand that at the very beginning, 2012, Dr. Xu Yingjia, that has published the very first paper to make a retrograde analysis, make a three vessel IVUS to identify the calcific nodule by IVUS. At that time, she reported the prevalence of calcific nodule was 17% per artery or 30% per patient in the ACS group of the patient. Very interesting. I think it's also due to the limitation of the resolution of the IVUS. She reported that the natural history of the calcific nodule recognized by IVUS is no different between the calcific nodule group or the non-calcific nodule group. Later in the year 2017, we can see Dr. Li reported this kind of another study by OCT, which reviewed over 889 patients in the ACS cohort. However, the report indicated that 16% of per vessel or 30% per patient in the non-corporate lesions of patients with ACS using the three vessel OCT identified the prevalence of the 4.2% of all the lesions. Also, if you pay more attention, you can see the calcific nodule is mainly located in the proximal mid segment of RAD and RCA. This is another study that involving 3,000 patients with eruptive pre or post intervention OCT, including this one, reported the calcific nodule prevalence is 7.3% in this kind of cohort. And also, if you pay more attention, you can see the eruptive ones and the non-eruptive ones in the RCA mid segment is a little bit difference. So to summary, we can see that in different cohort, the eruptive calcific nodules is around 3% to 4% in the ACS cohort. The third part is the pathogenesis. Currently, the mechanism of calcific nodule formation is not fully understood yet. It is believed that the both mechanical and the biological factors jointly contribute to the formation of the calcific nodules. Calcific nodules frequently occur at the coronary hinge motion sites, such as the mid segment of the RCA, as we just mentioned, or the bifurcation of the left main coronary artery, for example, the proximal part of RAD and circumflex. Continuously mechanical stress from hinge motion repeatedly triggers the calcific plate rupture, causing the calcified necrotic core with low tensile strength shattered into the multiple fragments, damaging the capillaries, which induce the intraplaque hemorrhage, etc. So this kind of result can help to form the protrusion of the shattered calcific pieces to protruding into the vessel. However, this kind of mechanism does not explain all the kind of calcific nodule, because we know there is a eruptive calcific nodule, there is non-eruptive calcific nodule. So how does the mechanism form? in the non-eruptive calcium nodule. One important mechanism is that the collagen matrix was present in the calcific segments proximal and distal to the eruptive and non-eruptive calcium nodules. It was absent at the site of calcium nodules within the necrotic core. So it is one of potential mechanism that causes this kind of non-eruptive calcium nodule formation that is bond regulation, I mean, the amount reduced in the collagen of in the non-eruptive calcium nodule. Other factors also can be included that can contribute to the formation of the calcium nodule. For example, the abnormal deposition of the calcium salts, and also the molecular mechanism. For example, the calcification process involves molecular regulation by, for example, BMP2 and MGP, etc. There different kind of regulation disorder can contribute to the formation of the calcium nodule. Nowadays, we all understand that the calcium nodule can be mainly divided into two types. One is eruptive ones, another is non-eruptive ones. The first one is always can be detected on non-occlusive luminous rhombus and multiple nodular fragments of calcification protruding and disrupting the overlying fibrous cap. And the non-eruptive ones were also named as the nodular calcification, were detected within the plaque and correlated to the extent of the underlying calcification with a thick, intact fibrous cap separating the necrotic core from direct contact of the lumen. However, another very important form of the calcification, severely eccentric, is I think is long time ignored, which is called the protruding dense calcium, which is like the third one on this picture. This one is not recognized as a calcium nodule before. However, we all understand this kind of a very severely eccentric kind of a protruding calcification. We can see that it's very dense, like a whole very dense block of calcification that protruding into the vessel wall. This kind of disease is also associated very severe under expansion or very high stanton symmetry. However, it's not been, I think, it's paid attention to. So this kind of calcification, should it be evolved in another type of calcific nodule or not, even though the formation mechanism is different. So I think this is a very interesting topic. Here on this table, we listed the different signs from the OCT of these three kind of, calcification. We can see that the calcium protrusion, there is no obvious signal attenuation, and also it's very, how to say, severely affected the stent expansion. So among these three kinds of calcification, we can see the patient and anatomy characteristics is a little bit different. One is that the protruding calcium on angiography is, we can see, is not obvious, and also the angiographic radiolucent mass by the protruding calcium is not obvious. The rest from the OCT, either the arc of the calcium or the surrounding calcium at the calcium nodule were the same, similar. Natural history of untreated calcium nodule is very important because we need to know which one is bad and what kind of a prognosis that it influence. In a study by Sugin, etc., that only include patients with ACS, they retrospectively analyzed 600 ACS patients receiving PCI, indicating that calcium nodule was associated with high risk of major adverse cardiac events, which means that the calcium nodule is an ACS trigger, which means if you do not treat it, it is going to trigger very high miss events during ACS patients with a follow-up 3 years. Another sub-analysis of CLIMA study, including 1,700 ACS patients in the 1-year clinical follow-up, indicating that we can see the eruptive calcium nodule is the worst. We can see this kind of event-free survival line by the red line, eruptive ones. It's caused the most, miss events or ACS events during the follow-up of 1 year. So which indicating that eruptive ones is a major trigger of ACS events, unlike the non-eruptive calcium nodule and no calcium nodules lesions. So now that we understand eruptive ones is the most dangerous that trigger of the ACS events. So next problem is how should we treat this kind of lesion? Currently, that under the guidelines of the expert consensus, stent expansion and avoid stent edge problem is our main theory to promise to the prognosis of the patient. However, is it enough for calcific nodule lesions? The answer is probably not. So we can see there is a case report indicating that different acute effect of PCI on different types of calcific nodules. The left ones is eruptive ones. So we can see after the stent expansion and plaque modification, the stent expand very well. It's like a perfect circle, and the stent expansion is fine. However, on the right ones is the non-eruptive calcific nodules. We can see the stent expansion, the stent symmetry is poor. So theoretically, maybe the eruptive ones is easier for stent expansion. It's maybe associated with a better prognosis. However, is the result like this one? This is another analysis indicating eruptive calcific nodule is more easily to be disrupted or deformable. We can see that eruptive ones during the stent expansion is more easily to be, disrupted or expanded. And also different kind of types of calcific nodule, for example, the concentric, eruptive ones or the non-eruptive ones, we can mainly the eruptive expansion is relatively good. And also different kind of analysis are indicating that eruptive calcific nodule is maybe associated with almost 100% stent expansion. However, the undeformable of non-eruptive calcific nodule is, relatively 35%. And this is other better stent, stent expansion figures that involve of this one. However, the stent expansion in the eruptive ones is good, but the prognosis of the eruptive ones is poor. So this is very interesting that when the stent expansion in the eruptive ones is good, but the prognosis is poor. And also we can see that eruptive ones, whereas non-eruptive ones, the 2-year follow-up with the target lesion failure is very high. And also studies indicating that this kind of eruptive ones, this kind of target lesion failure is mainly within the 180 to 365 days. This is a peak that for the MACE event. So how does this kind of target lesion failure so high in the eruptive PCIs? Clinical studies using 249 lesions are undergoing intravascular imaging and rotablation in the severely calcified patients, indicating calcified nodule patients. We can see although that you accept this kind of rotablation in the severely calcified patients, we can see during the follow-up of 1 year, this kind of target lesion failure was significantly higher in the calcified nodule group in the non-calcified nodule group. So indicating that this kind of calcified lesion, calcific nodule related in-stent restenosis is the main cause of target lesion failure within 1 year. So finally, how should we treat this kind of a calcific nodule? Like we mentioned, the stent expansion maybe is not enough. So how should we do it? Sadly, currently today, we do not have a straight answer for this one because nowadays we still lack the large RCT studies that prospective observations of the eruptive ones or non-eruptive ones or compare the different kind of modification techniques in the eruptive PCIs. Several studies on consensus give us suggestions. However, different suggestions is offered. We do not know how to do it. But currently, we think that the debulking strategies like the rotablation, intravascular lithotripsy, or ELECA, I think is the main tool. Like the rota is the main debulking strategies. With the favor of wear bias, we can see sometimes it can reduce the amount of calcification. And also studies on the calcific nodules using rota has some research. Sadly, currently we do not see rotablation on the calcific nodule can reduce the MACE event in the future. Like in this study, 204 patients with calcific nodule were divided into the rotablation group and non-rotablation group. So during the follow-up at 1 year, there is no difference between the rota group and the non-rota group during the follow-up. However, here is some courtesy from Dr. Kashima. Some wear bias adjustment strategies may potentially help us to increase the effect of rotablation. And also the SEC expert consensus indicating the Burr ratio may be more aggressive to the 0.6 to 0.7 ratio, and also the where with extra support and other devices could be used. Shockwave is a good tool. However, for the calcific nodule, currently Dr. Ali indicating the paper, intravascular lithotripsy is a safe and effective one for the stent expansion. He reviewed 260 patients with calcific nodules and identified 21% of the lesions, and also indicating that IVL is safe and effective in the calcific nodules. And also, like in this study, the follow-up of 2 years, that after using the intravascular lithotripsy, that we didn't detect any difference of target failure between the two groups. And also, other studies also indicating this kind of calcific nodule is, how to say, very large in the body, and the IVL stent expansion and lumen gain are comparable between calcific nodule and the non-calcific nodule lesions using the intravascular lithotripsy. ELICA is a good tool, but there is still limited data for the for this kind of usage in the calcific nodule. One thing is for sure that this kind of tool usage can help to debulk, to reduce amount of the surface of the calcific nodule and help the stent second time expansion. So some flowcharts can be used to guide us how to use this kind of tools to prepare calcium nodule. And a very simple case here, left main bifurcation with the severe calcification from the CT reconstruction. This is a unique technique raised by Dr. Li Yue in our hospital. And we can see this kind of distribution in the left main bifurcation is very severe, which is agreed from the previous indications. After ROTA, using the OCT and IVUS within one catheter scan, we can see that very severely calcific lesion within the bifurcation. And after that, we use 2 shockwave balloons, and the final result is very good. We can see multiple cracks during the surface of the calcification, and stent expansion is good. So finally, some take-home message. There are 2 types of calcific nodules, eruptive or non-eruptive ones, with one potentially calcium protrusion. That is interesting question whether to join the calcific nodule or not. Untreated eruptive calcific nodule had worse outcome, and the eruptive calcific nodule can be deformed and has a better stent expansion, however, with a worse outcome in the future follow-up. Atherectomy shockwave may work, but need long-term outcome data. Due to the limitation of the time, I think this is all the information for today. Thank you for your attention.
Okay, thank you, Professor Chao Yang. Thank you for your excellent lecture. And really, calcium nodule is challenging lesion, and there are still many questions need further research. And the Interventional Cardiology Council of Asian Heart Society are planning to make expert consensus on the calcium nodule. We could discuss later, and let's invite Professor Yao to host the next presentation.
Thank you, Professor Lee. It's my pleasure to co-chair with you this very important research seminar organized by the Asian Cardiovascular team. So we are very honored to have Dr. Zhang Mingyou from the First Hospital of Jilin University, that he is going to present a talk on coronary artery calcium imaging studies and case reports. So we go to the CV of Professor Zhang. The next PowerPoint, please. Yes, Professor Zhang is the Associate Professor of the First Hospital of Jilin University. He is a very famous interventionist in China, and he holds a lot of key academic appointments and memberships, including the intravascular ultrasound fellow of the Cardiovascular Research Foundation, as well as members of the Council of Cardiovascular Radiology and Intervention of the AHA. So without further ado, I would like to invite Professor Zhang to present his PowerPoint today. Thank you, Professor Zhang.
Thank you, Dr. Yao. Thank you for Professor Lee, Dr. Yao. And it really is my honor to have this chance to present my topic. The topic for today is called Coronary Artery Calcium Image Study and Case Report. I'm Ming Zhang from the First Hospital of the University. Talk briefly about history. The modern cardiac catheterization actually started from the 2099. Wiener Forssmann started the first catheterization for the cardiac procedures. So after that, Sonis started the first selective angiogram. Accidentally, he was intended to do the angiogram for the aorta. The catheter accidentally slid into the right coronary, so we got the first image of the selective angiogram for the cardiac coronary arteries. So the intervention was started actually from the half centuries ago, angiogranizig, to this patient, the first patient actually did the 23 years later for the follow-up. The upper right image showing the picture 23 years later after the PTC, the treatment coronary artery is still wide open. It's kind of miracle. To memorize this, Dr. Granizig, this picture published on the New England Journal of Medicine in 2000. The major breakthrough for the modern era of the cardiovascular intervention, I think it should be the coronary artery imaging and coronary artery physiologies. The coronary artery imaging mainly including the IOS and OCT. So based on the information, based on the understanding with the coronary intravenous imaging, we now can quite understand the underlying reason for the ACIs is actually caused by the plaque rupture, followed by the plaque erosion, and in some of the few cases caused by the calcified nodules. So from the perspective of the atherosclerosis, the pathology for the coronary disease actually started from the atherosclerosis. At the beginning phase of atherosclerosis, the lipidic streak, fatty streak, then develop into the lipidic pool. Lipidic pool can progress to the necrotic course because of the macrophage and the smooth muscle cell involvement. Whenever we see the necrotic core, the coronary calcium already start. In other words, whenever we see the coronary artery calcium, indicating the advanced lesion, the necrotic core formation in the coronary arteries. So in the real advanced phase of the atherosclerosis or the real advanced phase of the coronary calcium, we already see some osteoclast cells activities and literally see some bone surrounding the coronary arteries. So that's why the real advanced calcified lesion or severe calcified lesions really challenging case to treat. Based on the distribution of the calcium, we classify the calcification into the superficial calcification or the deep calcifications. Because the limited penetration of the OCT of the light signal, OCT IOS obviously is more sensitive in the detection of the deep calcium. A more clinically relevant way to differentiate or categorize the calcification is based on the thickness of the calcium. So if the calcium is thin, it's easier to break. So usually the stent expansion can be achieved better with a better result. If the calcium is thick, sometimes it can be challenging case and it's causing more under expansion and it can cause more complications. With the OCT development, we initially have the OCT-based calcium scoring because OCT have an advantage to describe the contour of the calcium. We can have the information of the thickness of the calcium. So originally, from 2018, in the intervention, published the original OCT-based calcium score, including the maximum calcium angle, the maximum calcium thickness, and the calcium length. From last year, they updated the new OCT-based calcium. The new OCT-based calcium actually is more clinically relevant. So the new OCT-based calcium scoring, including actually is the severe calcium length. If the length over 3 millimeters, and if the calcium is circumferential is 360 degrees, or the minimum cell calcium thickness over 0.3 millimeters. Based on the previous study, earlier study in the CRF, I analyzed the severely calcified lesions after the stent. We measure the pre-calcified lesion characteristics and do the regressional analysis to find the clinical relevant factors to involve impacting the stent expansion. And mainly, there are 4 points to closely related to the stent expansions. The length of the severely calcified lesion, if it's over 5 millimeters, or the circumferential calcification. The presence of the calcified nodule sometimes can impact the stent expansion. And also, if the vessel diameter is small, the stent expansion tends to be less. Within the derivation or validation cohort, we also very good correlation with the calcium score and the stent expansions. Here are 2 typical examples of the 2 cases showing the first case with the calcium score only 1, we achieved a really good stent expansion with 98% of stent expansion. In the case number 2, the calcium score is high, we achieve barely over 50% of the stent expansions. So with atherectomy, we still didn't reverse the trend. Higher calcium score indicating the lower stent expansions, but we significantly improved the stent expansion overall. So then I'm going to present a few cases we did previously showing the treatment of the calcification. The first case is 62 years old male. He come here with the unstable angina. Here is the index diagnostic C angiogram. So the lesion is in the proximal LAD. The spider view showing the calcification in the proximal LAD and the tight lesion here. Right coronary artery, there is a lesion in the proximal segment of the right coronary arteries. We are going to leave this one for the stage PCI. So the target lesion for this time, we are going to try to treat the proximal lesion for the LAD. So routinely, we treat this lesion with the 2O balloon for the pre-dilation. We give 18 atmosphere pressure. We find that there is a dent inside of the balloon. So we use a Wuren carting balloon 2.5 for the pre-treatment. After the carting balloon, we use a non-compliant balloon 2.5, giving the really high pressure from 20, 22, all the way to the 28 atmosphere. So after 28, we still clearly see there is a dent inside the ballooning, inside of the balloon. So after that, fortunately, we can deliver a catheter to the distal segment. From the pullback, we can clearly see the severely calcified lesion segment is really long. We see a calcified nodule, and we see the multiple segment of the circumferential calcifications. So in total, the calcium score is over 3. So we use the atherectomy with 1.5 BER for the rota ablation. So this is a pre-rota. This is a post-rota image. So after rota, we using a 3O balloon for the post-dilation. Here, the dent in the middle of the balloon disappeared. Then we tandem place the 2 stent in the mid and the proximal segment of the LAD lesions. So that's the final angio. Spider view for the final angio. Angiographically, the expansion of the stent looks good. Though we confirm with the IWAS, I think we are happy with the final result, which is 5. So the second case is 81 years old male. He come here ACS. This patient is a non-STEMI patient. This patient angiogram showing really diffused calcium in the circumflex and LAD distal left main, and the tight lesion actually located in the distal left main. And also, the proximal segment of LAD show the severely tortuosity. the right coronary artery also have diffuse disease. The target lesion for this time, we are trying to treat the LAD first. Because of the severe calcification, we use the rotor ablation with the 1.5 Burr straight away. So this is a rotor ablation. After rotating, we deliver a 2.5 balloon to the post dilation at 18 atmosphere. After the ballooning, we deliver IVUS catheter for the assessment. With the IVUS checkup, we find there is a diffused calcified nodules, and also we show some vessel damage because of the rotor ablation. We placed the 2 stents in the middle section and the proximal side. That's the delivery of the stent, deployment of stent. And this is the final run with the IVUS. The last case is 82 years old female. So this patient come here with the presentation of the non-STEMI. This patient had a CABG history, 16 years old, 16 years before she received a CABG. Before the procedure, we did a CTA to evaluate the bridging vessels. The CTA show that the bridge to the LED and the circumflex are patterned, so the RCA is occluded. So we did angiogram after the CTA. The circumflex is occluded, and there is a diffuse disease in the left main. LED also occluded. So because the CTA is showing the patterned LED and the circumflex bridging, so we don't want to treat the left coronary artery again. So here is the right coronary arteries. So the target for this time, we're trying to treat the RCA. Actually, after we see this RCA imaging, we are kind of happy because we see the RCA looks like it's open. It's not a CTA lesion, not a CTO lesion on the right coronary arteries. That's a angiogram for the lemma. The lemma looks quite healthy. The wire is easily to deliver to the distal vessels. Initially we are using a GR4 regular guiding, but quickly we find this is a mistake. The 2.5 balloon won't pass, so we using a smaller vessel. Even the smallest vessel won't pass. So we have to we are trying to using with a Godzilla for the to help the delivery of the device, still failed. So we switch to the M+ for the stronger backup. After switch to the M+, we still can't deliver this balloon. Even the smallest balloon won't pass. So we have to think about the next step. So we have to using the rotor ablation to rotate the ostium of the coronary artery, the ostium of the RCA. So we choose the 1.5 Burr for the rotor of the ostium region. That's the rotating process. This rotor I think personally, I think this is the hardest case I did in the rotor. Multiple times, if not 30 or 40 times. It's really hard. Every time you're trying to push the Burr advance, the guiding is going to slide out. It's beauty with multiple times attempt. Finally, we have some progress. I think here we show we finally can deliver the Burr going to the mid section of the RCA. So that's the finally we did many times for the rotor. Finally the rotor rota can pass the lesion. Then we using IWAS to evaluate the calcium after the rota. So obviously the circumferential segment is really, really long. So that's why it's really so hard to deliver all the device and to expand the calcium lesions. After that, things get easier. So we deliver two stent in the midsection and proximal to the all the way to the ostium of the RCA. That's the final result. We achieved the MSA about a 5. So basically, the stent expansion is acceptable. That's all. That's all the key support. Thank you for your time.
Thank you, Professor Zhang, for the very nice cases that we have showed the importance of imaging as well as the management. So we shall move on to the next speaker. So I will pass to Professor Lee to introduce myself.
Okay, the next speaker is my co-chair, Professor Yao Jiheng. The topic is pretreatment device selection for calcified lesions. Dr. Yao, please.
Thank you for the introduction. Let me share the screen. Right. I hope you can all see this. So can you see this screen? Yes, Professor Lee?
Yeah.
Okay, so in the next 20 minutes, I will talk about the pre-treatments of device selection for calcified lesions. So I will split the talk into 5 sessions. Introduction to calcified lesions. We know as interventionists, calcified lesions is still one of the major challenges for us in managing patients with ischemic heart disease, other than chronic total occlusion lesions. Now, the reason why calcified lesions is a challenge is because, as obviously, we have several reasons, including the device may have difficulty to cross the lesions, even balloon, or not to mention stents. There could be dissections when we are trying to use high pressure balloon in opening of the vessels. And in extreme cases, there could be even stent dislodgement or impingement to the vessel. So calcified lesion is always a very big challenge to us. Not only that it will prolong the procedure, but the safety of the procedure is also much higher and more difficult for these kind of calcified lesions. As a result, the treatment of coronary calcified lesions, as mentioned here, is like tunneling through a rocky cave, becomes very important treatment strategies for us to manage these patients. So mentioned by the 2 previous speakers, we know there are different strategies, including rotablations, shockwave balloon, etc. So in this particular talk, we try to make a summarize of these important method and how pre-treatment planning becomes essential when we are deciding what is the treatment to. As I mentioned, pre-treatment evaluations is important. So usually, how do we evaluate patients with calcified lesions? Now, CT scan is a non-invasive imaging that I think most of the cardiologists would offer to patients with suspected ischemic heart disease. In the old days, we have the coronary calcium score for correlation with underlying atherosclerosis. But nowadays, with better CT scan and of course with concomitant contrast injection, we do have a very good assessment of CT based calcium coverage or calcium cephality just based on the non-invasive CT alone. However, we know that this calcium thickness cannot be properly assessed because we know that there are some criteria or there are some high risk features for us to quantify the severity of the calcium. So CT scan will still have its limitation, not to mention the blooming artifacts and the difficulty of assessing the percentage of occlusion by contrast study. Moving on to CT, of course, the next step is to do invasive coronary angiogram. I think there are examples already shown by my previous speakers that even based on coronary angiogram, as in these examples here, even without contrast, we can already see the calcium. So for new interventionists, we know if we can see a calcium that's synchronized with the heartbeat, probably this is a calcium that is embedded within one of the coronary arteries. And we can also look at the severity of the calcium by whether this is a 360 degrees or the thickness of the calcifications can be estimated even by the coronary angiogram. But of course, we want better assessment. Okay, so with our two previous speakers, we know there are imaging properties, invasive or intravascular imaging properties, including the intravascular ultrasound, which of course is very important when we assess patients not only to quantify the obstructions, but also to quantify the calcifications. However, we know some of the limitations of IVUS is that it cannot measure the thickness behind the calcium or the leading edge. So therefore, we probably cannot assess the amount of calcium within particular lesions. However, we do have some properties that we want to derive from the IVUS so that we can risk score these patients, including whether this is a circumferential calcium, whether the length of the calcium is over 5 millimeters, the diameter of the vessels, or as our first speaker has mentioned, a calcified nodule. So these are some of the high-risk features that we want to look at when we do intravascular ultrasound for our calcified lesions patients. For the AHA classifications, as shown in the lower table, we know these are the different grading for the arc of the calcium that would help us to judge what is the treatment plan for these patients. OCT, as mentioned by Professor Zhang before, is also another very important intravascular imaging for us to classify these calcifications, which I will not reiterate. However, one of the key difference from IVUS is that it can really give us a full extent of the calcified plaques, including the thickness and volumes, so that we can use this as one of the risk factors or the scoring system for OCT. So this is just a summary table for CT scan, coronary angiogram, as well as the OCT and IVUS that would help interventionists to see the benefits of these different methods for us to assess our calcified lesions. Now we move on to the very important part of this talk is the selection of the device. So we know there is a calcium problem, we know there's a calcified lesions, we know the severity of the calcified lesions. So what do we do? How do we choose our device for treating these calcified lesions before we put in a stent to treat the atherosclerosis? Well, before we go into cutting balloons, scoring balloons, rotor ablation, etc., I think one of the very key factors that would improve our successful treatment for calcified lesion is a good support, okay, including the guiding support as mentioned by the previous speakers. Maybe an AL would be better for calcified lesions. We have guide sealers, etc., microcatheters, or even other technique, dual wire technique, anchoring technique that would help us to deliver our balloons or other tools for that calcified lesions. I know tortuosity, etc., would also be a challenge. Now, the first and I would call with the most experience or the easiest for us to do is the cutting balloons and the scoring balloons. We know that these cutting balloons is a non-compliant balloon with micro blades on its surface, such that when we want to open up, usually for calcified lesion that is mild to moderate rather than severe calcifications, a cutting balloon or even a scoring balloon would be sufficient. Okay, the scoring balloon, because of the semi-compliant and also the scoring elements of the surface, the passage is usually a little bit better than the usual cutting balloon. Okay, the reason for it is to fracture the calcified structures. Another balloon that we might want to do is high pressure balloons. Okay, for example, the OPN balloons, we know it can inflate up to 35 ATM. So for very, very tight lesions, calcified lesions, if we could deliver the OPN or high pressure balloon using high pressure, may be able to crack up the calcified lesions and to enlarge the lumen. Now, of course, we have to mention rotablation, all right? So we know there are small diamond crystals on the distal end. We have cases already shown, so I will not talk too much, but we know that the blur diameter would range from 1.25 to 2.5 millimeters, so that we know we have to choose the size of the rotablator, depending on the vessels that is having the calcifications. Now, another technique or rotablation technique that we would have is the orbital atherectomy. So this is the diamond-coated crown to reduce the calcified plaques, which differs from the rotablation by that it can be a bidirectional rotablating or atherectomy. So this is another technique that we might want to use for patients with very severe calcified lesions. Now, in extreme cases where even a rotor wire cannot pass through that particular lesions, we might consider this excimer laser corneal atherectomy, that we can use this to open up the vessels before we deliver other instruments such as rotor ablation. So these are for very tight lesions, calcified lesions that even a rotor wire cannot cross, or microcatheter cannot be crossed to exchange our wires. Nowadays, I think everyone knows that we have now new methods, okay, to open up a calcified lesion is, of course, the intravascular lithotripsy, which delivers acoustic shock waves to fracture calcium in patients with heavy calcifications. Of course, this is different from rotablations and differs from the usual cutting balloon, and that the size is 2.5 to 4.0 millimeters. All right, so at least we have to open up the vessels either with rotablation, etc., and then we can deliver this balloon. Okay. However, in other cases where the calcium is a lot, that is causing a lot of burden, where rotablation is not the problem because maybe the balloon can pass, we can still fit in a intravascular lithotripsy balloon, for example, the shock wave, to open up the vessels and to crack the calcium. So there are already studies trying to demonstrate the safety of the combinations of severe calcified lesions with rotablation, so with rotablation plus other methods. For example, this particular study showing that after rotablation, we do cutting balloon, or rotablation, we use non-compliant balloons. Both of these methods seems to be safe and feasible, okay? This is one study that I would like to share. Another study is the rotatripsy, where this is to assess the safetiness of doing rotablation followed by lithotripsy. Okay, so this studies involve 34 patients, okay, and seems that all patients are having good results with this rotatripsy approach, such that we know that for very extensive calcified lesions, using multiple strategies is also an option, okay? So we have different tools to help. Finally, this rotor shock study is another evidence to show that over time, not only that the procedure is safe, but the overall target vessel revascularization rate is only 5.6%. So overall, this is a safe method. Now, we have different strategies. So how do we choose? So these are the flow charts that has been developed by the experts. For example, using the angiogram, if we can cross the balloon, we go ahead with everything. But if we cannot cross the balloon, we start with the rotablation, etc. Okay, and then we do the cutting balloon, lithotripsy balloon if necessary. So this is without doing any intravascular ultrasound, just based on angiogram derived calcium cephality. Now, if we are lucky enough to get the intravascular ultrasound in, or the OCT in to the lesion for assessment, then we can use different scoring system to help us to decide whether this calcifications is in fact a long lesions, whether this is a high calcium arch, a big calcium arch, whether there's calcium thickness, or even there's a presence of a calcified nodules. So based on these different scoring systems, we would like to choose our instruments carefully. So if this is considered to be a high-risk patients or high calcium burden patients, we go with the lithotripsy balloon rotational atherectomy, etc. And if these are considered to be a less calcified lesions, of course, we can use cutting balloon or scoring balloon, high pressure balloon, etc. Now, there are also the SCAI expert consensus, which is quite similar, okay? But of course, we also emphasize on the intravascular imaging, okay, whether there is calcium modifications. But of course, in China alone, maybe perhaps some of the patients may not have the financial support to do the intravascular ultrasound. But if we do have that, we would always want to do an intravascular imaging, either IVUS or OCT. But if not, then we can use the usual balloon method. And then if it cannot pass, then we will go for the atherectomy, etc. So this is just to combine depending on the availability of the intravascular imaging technology. Now, this is another Chinese expert consensus that, again, is showing that the importance of the lesions, classifications, and a proper assessment, for example, using IFS on the right side, that we want to grade the lesions, and whether if this is a severe lesion, we will not waste a lot of time by trying cutting balloons, non-compliant balloon, but we should go directly to the rotational atherectomy, because we know by putting in balloons, we are actually not opening up the calcium, but we might create damage, for example, dissections, which will make the procedures even more difficult in an already very complex case. Now, for the OCT assessment, again, we can do this assessment, but focusing on whether the patient have any deep calcifications or whether this is superficial calcifications. And if this calcifications has a high score, again, we would consider rotational atherectomy, followed by assessment whether this is fractured and doing non-compliant balloon or lithotripsy, etc. So we have different methods already to help us to classify these lesions, not only just to know the prognosis, but also to help us to decide which strategies, which instruments which help us the best to carry out the procedure. So for the final 5 minutes or so, we will just share a case that is done in the Hong Kong U Shenzhen Hospital. A 55-year-old man with the usual chest discomfort, history of hypertension, etc. He had a history of kidney transplantation. I'm sure that all of you know that patients with kidney disease, they would have a lot of calcifications, because there is a term called the Mockenbach calcifications, where the calcium is usually located in the media of the intracoronary. So patients with kidney disease, you know, they are prone to coronary calcifications. So this is the corneal angiogram of the left system of patients. We can see that the LAD is calcified, but without any heavy or very significant obstruction. But of course, we can see that the left circumflex, although it's not a dominant vessel, is completely blocked. Now, we look at the right. Now, the right coronary, in fact, has significant calcifications and significant obstruction. So given the dominance of the right coronary arteries as well as the symptoms, we decided to go for coronary interventions to the right RCA systems with a calcifications of 80%. So we use the cutting balloon, okay, but seems that the cutting balloon cannot pass to the mid segment, okay, as highlighted in the yellow. So that we try to use different strategies, but still this is not dilatable, and obviously the IVUS cannot pass for us to even properly to classify the calcifications lesion nor microcatheter. So of course, without further ado, we would go ahead with the rotablation as shown in this particular angiogram here. So we use a 1.5 blur to open up the vessels. Of course, with the 1.5 blur, we are able now to deliver the intravascular ultrasound to the patient. I will not go over the whole image. And we also proceed with the OCT to the patient and to try to look at the calcifications. In fact, there is extensive calcifications, although we have some cracks, but seems the calcification is still very heavy. So therefore, the thickness is more than 0.5. Obviously, it's very thick calcium and with a high calcium score over 4. So therefore, we go over with the algorithm with the after the atherectomy rotablation, we go to the intravascular lithotripsy with the shock wave of 4.0 decided by the OCT imaging. So we can see that there is a gradual dilatation of the vessels with the shockwave balloon with good results. And with the OCT, we can see a perfect crack of these particular calcified lesions. For example, on the top is the before the lithotripsy, and below is the lithotripsy. We can see the dilatation of the vessels as well as the cracking of the calcium. And finally, we put in the usual stents for completeness of the procedure with excellent results. So this is the post-OCT. So I believe that without the lithotripsy, without a proper preparation by the rotablation, we would never achieve such a beautiful or a proper expansion of the stents in this particular calcified lesions. So in summary, Chairman, ladies and gentlemen, so it's my pleasure again to share these important methods as well as the pre-treatment strategies for patients dealing when we are dealing with calcified lesions. So this is a summary table here that you can take a note, and that we have different strategies. Okay, I wouldn't go through them, all of them here, but we know that there are different strategies, and different strategies would be suitable for different situations. Okay, so we know this is a challenge for treating calcified lesions, but that we should be confident that with a proper algorithm, a proper planning, understanding of different instruments, the treatment results will usually be optimal. So thank you once again for the very kind introduction, and we should discuss after these 4 talks.
Okay, thank you, Professor Yao. Thank you for your excellent presentation and tell us how to select pre-treatment device for the calcified lesion. Because of time limitation, let's move on to next presentation. And the final speaker is Professor Ye. Professor Ye is a very famous and well-experienced interventionalist in China, and he's a chief physician of Nanjing First Hospital. He's coronary heart disease interventional training tutor of National Health Commission and member of SKY and member of the Professional Committee of Cardiovascular Disease Management in China Association for the promotion of international healthcare exchanges. Deputy head of the coronary imaging and physiology group of the Chinese Medical Association Cardiovascular Society. And his topic is timing of initiation and endpoint selection for calcification debunking strategies. Professor Ye, please.
Yes, thank you. Thank you very much for Dr. Lee's. And I cannot find it here. Yes, could you see my slides?
Yeah, okay.
Thank you. Thank you, Dr. Lee's invitation for me to be here. So my topic is timing of initiation and endpoint selection for calcification debunking strategy. We also know the presence and the severity of coronary artery calcification plaque negatively impact angiographic and clinical outcomes following PCI. And the severe coronary calcification is also associated with suboptimal stent delivery, deployment, absorption, and expansion, which can lead to in-stent restenosis or stent thrombosis. And severe coronary calcification is also associated with incremental hazard of adverse clinical events, including deaths during 5 to 10 years follow-up PCI deficit, the use of new generation drug-eluting stent. Multiple technologies, including high-pressure balloon, modified balloon, ROTA, or IVL, can be used for severe calcified lesion to optimize the stent implantation. Intravascular imaging is very critical, important to determine the extent and distribution of coronary calcification and to avoid selection and the sequence of the use calcified and modified tactics such as previously. So that we also know the most important factors that determine short and long-term PCI success is the final minimal stent area. Coronary calcification leads to stent failure via two general mechanisms. First is calcification can lead to a decrease in vessel compliance, which prevents full stent expansion and opposition to the coronary wall. The second is the presence of calcification and subsequent vessel rigidity make delivery of equipment challenging. Difficult stent trackability, crossability, expandability, especially when coronary calcification is combined with vessel totus, which can lead to damage to the stent platform and polymer during repeat attempts to overcome a calcified segment. So previously, the distribution of calcification affects the final DES result, including four factors. One is the eccentric of calcification measured by the arc of the calcium. The second is the thickness of the calcium, measured as the distance between the abdominal and abdominal profile of the calcified component. The third is the depth of the calcified plaque component within the vessel wall. The fourth is the longitudinal extension of the calcified component along the course of the artery. We also have very useful tools to treat severe calcification such as rota, orbital, laser, and shockwave balloon. We also can use it in our daily practice, but how to select, as Dr. Han said, that we also to treat the different tools to treat the different calcification during the daily practice in our cath lab. We also know the rota is very popular in China for treat the severe to moderate calcification. The principle of the rota operation is one is a different cutting, which all disease plaque is in elastic. High speed rotational ablation can avoid hairs elastic vessel wall from plaque. Also, gonadal displacement of friction in a longitudinal direction between the guide wire and the device. High-speed rotational changes the friction vector to a circumflexatory direction. When we want to use a rota to treat a severe calcification, we also have many key elements of optimal rota tactic. For previous recommendation from a lot of country, a lot of doctors, we also want to select the maximum birth radial artery from 0.4 to 0.46. We don't have a definite ratio of this one. If we want to use 0.4, it means a modification to help us delivery stand below. If we use 0.6 with final ratio BER, we want to make the standard full expansion. We also select the rotor speed from the 140 to 150,000 RPM. We also use short ablation runs up to 15 to 20 seconds during the procedure. Unfortunately, when we think about the previous study focus on the debulking with the rota or orbit to NC balloon or modified balloon, we should step by step to study the trial again. The first randomized trial compared the rota to the balloon to treat moderate to severe calcification is a ROTEX trial. It is published in 2013. And we also find that there is a randomized trial compared with rota plus Texas and standard therapy with Texas implantation. Both patients was 120 in both two groups. But unfortunately, we can see the inclusion criteria, angiographic angiographic inclusion criteria, including the moderate to severe classification of the target lesion from the visual estimation. No intravascular imaging used was recommended in this trial. And we also find that here there is, there is no difference at 9 months clinical follow-up. Look at here, the cumulative including curve of death, myocardial infarction, target vessel revascularization, and the major cardiac events. No difference in two groups. So the conclusion, it tells routine lesion preparation using rotational atherectomy did not reduce the late lumen loss of DES at 9 months. Balloon dilatation with only provisional rotational atherectomy remains the default strategy for complex calcified lesions before DES implantation. We should focus on the limitation of ROTEX trial. First is a primary angiographic endpoint, no intravascular imaging data. The second is first generation DES used in this trial. The third is a final bird to vessel ratio was only about 0.5. This is a key point why we cannot get the good result from the debarking, just because the ratio was only 0.5. The fourth is indication of ROTA based on angiographic used in this trial. So when we think about the moderate to severe calcified lesion in the first randomized trial, is based on the angiographic data. The second RCTA trial compares with ROTA to the modified balloon with debarking technique. Both 100 patients was enrolled in two groups. One is use ROTA, another is a modified balloon to treat the moderate to severe calcified lesion. Unfortunately, all the patients' classification was depending on the angiographic estimation. No intravascular imaging used in this trial, but fortunately, we also cannot see any difference between two groups with modified balloon or rotational atherectomy with final instant late lumen loss, no difference in two groups. Well, for p-value was 0.02 for non-inferiority. That means compared with modified balloon rotational atherectomy with debarking technique did not show any benefit. The conclusion also showed us lesion preparation with upfront ROTA before DES implantation is not associated with excessively late lumen loss. A strategy of provisional modified balloon remains feasible, safe, and effective as long as spare-out rotational is readily available and may offer the advantage of compatibility with a small size catheter and less irradiation. So from these two trials, we cannot see any benefit from the ROTA with a debarking technique. Is that true? Is that real debarking concept during the daily practice? We also can see a very famous trial just published in this year in Nascent with orbit atherectomy with balloon angioplasty before drug-eluting stent implantation in severe calcified lesion eligible for both treatment strategy. It means epilepsy. But the patient was the number of the patient was very high in both two groups, nearly 1,000 in both in each group. When we think about the inclusion criteria, it is shown here. The lesion characteristics suitable for inclusion in the trial are the native delivered coronary artery targeted lesion with angiographic or intravascular imaging. So the severe angiographic calcified lesion definition was defined as the presence of radiopactis noted without cardiac motion involving both sides of the artery wall, with a total length over 15 millimeter calcium extending into the target lesion. This is only the angiographic definition for moderate to severe calcified lesion. So the second is if we use intravascular imaging, it is defined as over 270 degrees of calcium in at least one imaging crossing section. Low thickness of the calcified lesion, low length of the lesion showed in the trial. So we still did not get the good result from the orbiter compared with balloon angioplasty before drug into stent. We can see here the final median stent area or the mean stent area, there is no difference between two groups. The clinical outcome with the target vessel failure, there is no difference, even though we can see the orbiter group was a little higher compared with the balloon group, but we cannot see any difference. So how to interpret this result? The author tell us routine treatment with orbital atherectomy before drug-eluting stent implantation did not increase minimal stent area or reduce the rate of target vessel failure at 1 year compared with balloon angioplasty-based approach in severe calcified lesion, deemed eligible for both treatment strategies. This data support a balloon-first approach for most calcified coronary artery lesions that can be crossed and dilated before stent implantation guided by intravascular imaging. So why did we not benefit from debulking in calcified lesion in previous trial? So first, more than half these severe calcified lesion enrolled in these trials was only judged solely based on the result of angiography. If I was used for severe calcified lesion judgment, only criteria of over 270 degree calcification was used. Low thickness, low calcified lesion, low length of the calcification were used. So if we use a router to treat the calcified lesion with a debulking concept, with only the Berthoud vessel was only about 0.5. We also know a lot of characteristics of the calcified lesion will influence the stent expansion, including the eccentric or concentric, the depth of the calcified lesion, the thickness, and the length. We also know Dr. Zhang also told us that if we use IVUS, we have four characteristics of the calcified lesion. One is circle or over 360 or calcified lesion or the small vessel. Well, if we calculate the IVUS calcium score over 2, we should perform debulking or modification pre-balloon angioplasty. If we use OCT, we also can get this calcium score with circle or the length of the calcium lesion or the thickness of the calcium lesion. If the calcium score derived from OCT was over 2, adjunctive therapy with debulking technique should be recommended before stenting. So when focus on the previous algorithm approach for the coronary calcification, we should perform first a balloon angioplasty. If balloon cannot cross or balloon cannot full expansion, we should pay attention. Use intravascular imaging to guide us. If that doesn't work, is to use rotor first. Then after that, we should check the intravascular image to show the characteristics of the calcified lesion. So if we perform debulking, should confirm the debulking effect before stenting implantation. Ideally, intracoronary image should be done after atherectomy to assess the amount of debulking if there is adequate fraction of calcium and the degree of dissection. With a high resolution, OCT perform better in this regard. However, in case of deep dissection, forces and contrast injection can lead to worsening of dissection or hematoma. With IVUS, operators may see multiple revelation of calcium, which is suggesting of adequate debulking by atherectomy. Intimal dissection and calcium crack are associated with better stent expansion, while others found that decreased thickness and larger calcium arc with retention atherectomy are favorable factors of achieving cracks with a balloon angioplasty. So, and another algorithm showed as if we treat the calcification, shows this flat chode. But I'd like to use this approach algorithm for approaching coronary calcium based on intravascular imaging. Even though we use a debugging tactic before standing, we should make sure that there is optimal balloon expansion before standing. Even though we use intravascular imaging guided, we should use a 1-to-1 NC balloon to pre-dilate the lesion, calcified lesion before standing. Make sure that the balloon expansion well so we can put a stent in. So when we treat the calcification, we use debugging with a large bar size from this trial, but we don't have a lot of randomized trial. Often, all the presentation here, summary of the coronary artery calcification modification tools. We also has rotational orbits, laser cutting, scoring balloon, high pressure balloon, NC, OPN balloon, or literature, literature separate. We also, as Dr. Huang from Hong Kong tell us to treat the suitable tools to treat the calcification based on the characteristics from the intravascular imaging. So summary for my presentation, only based on coronary angiography, moderate to severe calcification is not the best indication for debugging. The best indication for debugging based on the coronary angiography are uncrossable or undilatable during PCI procedure. IVUS calcium score or OCD calcium score should be the best indication of debugging, which is also the time of initiating selection for calcification debugging strategy. Final bar to vessel ratio was about 0.5 with rota using is not the real debugging strategy. The best ratio is not clear, which means that endpoint selection of the calcified debugging strategy is not clear. But based on the intravascular imaging, we can see the calcium score decreased after debugging. Okay, we can select this is the endpoint selection for calcification debugging. So next, the clinical study with debugging strategy should be based on the intravascular imaging calcium score. Thank you. Thank you, Dr. Lee's invitation. Thank you.
Okay, thank you, Professor Yefei. Very interesting and wonderful presentation. We still have 8 minutes for us to discuss. Professor Yao and Professor Cao Yang, any question or comments for all the full presentation?
Maybe I would like to ask the first speaker, Dr. Chow, about the calcified nodule. So I can see you are in the airport. So thank you for spending the time to speak for us. So I think one of the very interesting concept that you share is for the calcified nodule is the eruptive versus the non-eruptive lesion. So we know that the clinical outcome of these two particular type of calcified nodules is different. So from your experience, okay, when treating a eruptive and non-eruptive, especially the non-eruptive, where you mentioned that the long-term outcome would be less, less favor compared to the calcified nodule. So when you see a non-calcified nodule, so a non-eruptive nodule, do you have some suggestion or any particular strategies that you think might help clinicians to reduce the subsequent adverse events?
Thank you, Professor Yao, and thank you, Professor Online. I think this is a very good question. So one thing is that nowadays we are at the stage that we understand the eruptive ones is worse, even though it's more deformable, understand can expand very well. However, during the follow-up of 1 year, within 1 year, the reprotrusion of the calcium nodule is very severe. So I think that this is the main issue for the eruptive ones. And nowadays we understand that the mechanism of formation of the eruptive ones and the non-eruptive ones and the calcium protrusion could be different. One theory is that the formation of the eruptive ones is highly likely similar to that of the vulnerable plaque. For example, at the initial, maybe, I just mean maybe, there is a very shallow calcium plate that is buried within, not so deep during the intima or something. And at the hinge motion point, maybe triggered by the plaque rupture or something, this kind of shattered and very small, nodular calcification got protruded or exploded to the vessel. And so maybe later formed an eruptive calcium nodule, so which triggers the following ACS events. And maybe sometimes during the full medication or something, these kind of eruptive ones could potentially healed and transferred maybe to the non-eruptive ones or calcium. This is just a theory. Nobody knows that. So to my knowledge on the clinical studies, we know that eruptive ones maybe, even though that you make a very full stack expansion following their guidelines and expert consensus, maybe within 1 year it's highly likely to the studies maybe 68% of the adult ones is associated with repercussion of the instant restenosis. So how to treat it? Maybe no one knows the answer currently. One thing is that if you use maybe a balloon dilation, I didn't introduce that because of the limitation of the time. Maybe pill balloon dilation or cutting balloon something. If the result is acceptable, once again, and following the consensus of the DCB guidelines, maybe DCB is the choice. However, one small number study indicating that using the DCB for the calcific nodules compares to the non-calcific nodules, the clinical result is still worse in the calcific nodules using DCB. However, the miss event is relatively fine. So my suggestion is that when you find an eruptive ones, if the lumen is not so small, and maybe I think that balloon preparation or DCB maybe a potential choice. However, you need a very precise and close follow-up. And if the lumen is not enough, my suggestion is that maybe under the guidance of Dr. Li, where we suggest that to use a debugging device. For example, maybe use a balloon to open the vial. If something still protrudes into the movement, maybe, using the rota or IVL is a potential choice. The whole idea is to debug, to reduce the amount of surface of the shattered that is not so stable, that is vulnerable tissue on the surface of the eruptive ones. However, once again, nobody knows that. Currently, all the flow chart suggested by the other experts is using the balloon. Majority of the time is NC balloon 1-to-1 ratio with the two different angles to observe if it can open well, and then use the DS. However, we all know that maybe it's not the best choice currently. So maybe I think that no one knows what's the best choice. Also, I want to know, Dr. Yao, what's your suggestions to this question? Thank you.
Thank you. I think I totally agree with you. Debulking is always the key strategies when we see calcified lesions, calcified nodules. But I think proper expansion, etc., would be important. But post stenting imaging, I would say this is also very key. Okay, to ensure that the debulking is okay, the expansion is good, etc. So and for other complications due to the intervention itself. So I think during the procedures, we try our best to debulk and do a post-stenting proper imaging, because sometimes, at the end of the day, we might be tired and we spend a little time to look at the post-stenting imaging. So I would like to ensure that all interventionists to do a post-stenting imaging, okay, to better quantify the success of the procedures. I think these are some of the key takeaways, because I think, as you say, there's no obvious treatment strategies that has been shown to be extremely useful for the eruptive type of calcified nodules. But I think also the post-stenting treatment, okay, ensuring that the lipid control, the risk factors control, is also very important, to ensure that the progression of the disease would be properly managed. But thank you again for the great questions, and have a safe travel. Hope to see you soon.
Thank you. Thank you.
Thank you.
Okay, I think we only have 1 minute. Okay,
Maybe you
thank
can do a conclusion, Professor Lee, do a conclusion
yeah.
for the audience.
Well,
Thank you.
okay, I think we should stop here. And thanks for the speakers. Thank you for your brilliant presentation today. And we will engage in depth discussion on the strategies how to deal with eruptive and non-eruptive calcium nodule. And at present, we are preparing to make expert consensus on the calcium nodule. Nevertheless, many questions in the field of coronary artery calcification still require further research, and we look forward to the development of more and better device and strategies in the future. And thank you all for participating in this conference and for your support of Asian Heart Society. The seminar is over. Thank you all. Bye bye. 再见，叶飞，
拜拜，谢谢
谢谢，
Professor Lee。